All right, a brief hello and welcome to those who are joining us. My name is Brad Lastly. I'm a physician assistant. I work at Advent Health Fatty Liver Clinic, and with me today I have one of my coworkers, Adrian Shepard, who is our nurse navigator at the Fatty Liver Clinic here at Advent Health in Winter Park. What we're doing today is we're actually going to be recording this lecture, this portion of the series, and we have a 4-part series that we're offering unique to our patients to help them better understand kind of the evolution of fatty liver disease. What is fatty liver disease? How do we manage it? And what are potential outcomes were we not to manage fatty liver disease well? So thank you again for joining us today. Our part 1 in this educational series is really understanding non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. Our purpose today is going to go through a slide deck of education. At the end of the slides or the series here, the webinar, we're going to take some questions in the form of the chat. And so we can definitely address any questions that you might have at this conclusion. We anticipate being done with the lecture in addition to the question answer session by 1 p.m. today. All right, so the liver, first of all, what is it? What does it do? Why is it important to have optimal liver health? So your liver is actually a fairly large organ in your body, and the liver performs over 500 different functions. So there's a lot of functions which we won't outline today, but to name a few, some of the more important functions the liver is responsible for is filtering and eliminating toxins. Your body has 2 organ systems that deal with filtration of your blood, one of which is the liver and the other the kidneys. The liver specifically will eliminate toxins such as alcohol or ethanol containing products, any sort of pollutants that you might kind of be exposed to, some work-related, some kind of your normal habitat or your environment, preservatives that may exist in the foods that you might consume, and any chemicals from your blood acting like a giant filter to keep those inner workings of your body balanced and well functioning so that you can maintain optimal health. Your liver also is responsible for breaking down, or we all call this metabolizing, fats, carbohydrates, proteins, and it really helps to stabilize your weight. So when you consume something, a food of any type, and it's high in fat, or it's high in carbohydrates, or it's high in protein, your liver actually works to break down those products so that it can utilize the fats, the carbohydrates, and the proteins in a way that helps allow your body normal function and to produce energy. We'll learn, however, that when your body is overtasked, your liver is overtasked with trying to break down fats, what happens to that extra fat that you've consumed and how that might deposit on the liver, leading to fatty liver disease. So the other things that your liver is very important for is it helps regulate various hormones in your body, okay? And without hormone control, sometimes that actually potentiates the chance for someone to gain weight. It also helps stabilize your liver, helps to stabilize your blood sugar and your cholesterol levels, which will create your glycemic control, okay? For the diabetics that might be joining us today, you understand that your kind of walk with blood sugar is a little more complex and complicated. But the truth is that when your liver is not functioning optimally, you cannot maintain your blood glucose as well. So as we move down the spectrum of scarring on your liver in the future, sometimes it's even harder to maintain blood glucose, requiring even more medications to stabilize your already abnormal blood sugar. Similar to that of cholesterol. When we think of blood cholesterol, we think of lipids and free-floating fat in your blood. And so when you think of free-floating fat in your blood and you think of your liver as a filter, your blood doesn't want free-floating fat. So the filter, known as your liver, will take that out, and as it filters it out, that fat, those lipids, are then deposited directly at the liver or at the site of the filter. Your liver also produces something called bile. Bile is an acid that's stored in the gallbladder and aids in your digestion. Some of you may not have gallbladders, so your liver will produce this bile and then immediately excrete it through your bile duct into your small intestine to help aid in digestion or elimination of your stool. So what is non-alcoholic fatty liver disease? Non-alcoholic fatty liver disease, also known as an acronym as NAFLD, N-A-F-L-D, it's really a condition where there's too much fat buildup, okay, above 5% in the liver if left untreated. This fat that builds up in the liver can actually lead to serious liver problems. It can lead to inflammation, and that inflammation as a result of the fat at your liver can lead to scarring, which is known as fibrosis. Fibrosis of your liver is on a pendulum. There's a scoring. Fibrosis stage 0, or F0 as we call it, is no scarring. Fibrosis stage 1 is minimal scarring, typically on the external surface of the liver. And as you move up in numbers, fibrosis stage 2, there's a little more scarring. Fibrosis stage 3, which we know as advanced fibrosis. And fibrosis stage 4 is also known as cirrhosis. So to recap, fat infiltration will accumulate on your liver. As that fat accumulates, it causes the liver cells to become angry, which results in inflammation. Prolonged inflammation of the liver leads to scarring. Scarring is also known as fibrosis. And then you start moving with persistent inflammation up the fibrosis score all the way until potentially cirrhosis. So you've guessed it, even in the absence of alcohol consumption, as our society has told us for years and years, you can develop cirrhosis or end-stage liver disease from fatty liver disease alone. So fatty liver should not be taken lightly. Some of you joining us, in your 6th, 7th, 4th, 5th, 6th, 7th, 8th decade of life know that, historically it's been, hey, there's a little fat on your liver, there's nothing to worry about. But just as time passes, medicine advances, and we understand that fat infiltration can certainly cause demise to the liver function. So now here in the last decade or so, we've really started taking fatty liver disease more serious as medical professionals and scientists have driven a better understanding of what this can cause. So please understand that accumulation of fat at the site of your liver above 5% defines non-alcoholic fatty liver disease. Further, non-alcoholic fatty liver disease is also defined as in the absence of alcohol. So if you currently consume alcohol, we may label you alcoholic fatty liver disease. One who drinks alcohol versus one who does not drink alcohol. Alcohol leads to fat accumulation at the liver, right? So diet, poorly controlled blood sugar, poorly controlled glucose, poorly controlled cholesterol and lipids, all of that can deposit fat at the site of your liver. Alcohol consumption can also deposit fat at the site of your liver. But when we label someone as non-alcoholic fatty liver disease, it means in the absence of alcohol, this individual has developed above 5% of fat at the site of the liver that can lead to liver inflammation. That's the risk, okay? If there is alcohol on board, we simply say, let's stop drinking alcohol. And hopefully your body will use that excess fat stored around the liver as consumption in an energy source. Everybody packages fat. Everybody packages fat at the site of the liver. That's its normal function. So as I had told you, remember the liver is responsible for breaking down, or what we call metabolizing, fat and starch and proteins. Well, that's its role. So everyone will have a degree of fat at the site of their liver at any given time. But when there's an appropriate amount of sugar or an appropriate amount of cholesterol, for example, it will then put too much fat at the site of the liver. And that excess fat is what we call fatty liver disease. Alcoholic versus non-alcoholic, depending on the presence of alcohol. Now, NASH, non-alcoholic steatohepatitis. This too is a condition that involves fat. The word steato means fat. Hepatitis means inflammation of the liver. Most people link the word hepatitis to viral hepatitis. Remember, there are viral hepatitis, such as viral hepatitis A, B, or C that are common in Western culture. But here we're describing inflammation of the liver as a result of fat. That's called steatohepatitis. In the absence of alcohol, we call this non-alcoholic steatohepatitis. In the presence of alcohol, we call this alcoholic steatohepatitis. The main difference between non-alcoholic fatty liver disease and non-alcoholic steatohepatitis is that non-alcoholic steatohepatitis, that fat has now led to the inflammation, which is like a swelling and damaging of the liver, which then risks that scarring, that fibrosis. So people who have non-alcoholic fatty liver disease are really not at great risk for developing scarring or fibrosis. But as soon as you move from non-alcoholic fatty liver disease and you develop inflammation as a result of that fat, your risk for developing scarring or fibrosis then increases. And if the liver scars enough, it leads to cirrhosis. And anyone with advanced scarring, such as cirrhosis or fibrosis stage 3 even, are at increased risk for developing a liver cancer known as hepatocellular carcinoma, which means in English that there's a cancer developing at the site of the liver cell. And that happens as a result of persistent, prolonged inflammation that's led to scarring. These patients with cirrhosis then are, potentially have to consider liver transplantation, as there's no return from a cirrhotic liver as far as the scarring is concerned. So, non-alcoholic fatty liver disease, no alcohol, fat accumulation above 5% site of the liver. If you leave that fat there, over time, you will eventually develop inflammation of the liver, which leads to scarring, known as fibrosis, eventually cirrhosis, and then increasing your risk for the development of primary liver cancer, known as hepatocellular carcinoma. So how do we determine kind of the difference as your healthcare provider? Do you have NAFLD, non-alcoholic fatty liver disease, or do you have NASH with that extra layer of inflammation? So if you have fat but no inflammation or tissue damage, the diagnosis is called fatty liver, or we also refer to it as simple steatosis, meaning it's just simply fat that's there. You've not actually caused any potentially long-term injury to your liver. But if you have fat, inflammation, and liver damage, the diagnosis is then considered non-alcoholic steatohepatitis. This one is the more risky version of the two. If you have a type of scar tissue in your liver cells called fibrosis, remember we talked about that, you may actually be on your way to developing cirrhosis. Fibrosis stage 0, normal healthy liver, no scarring. 1, 2, 3, that's advanced. Cirrhosis is fibrosis stage 4. So how common is fatty liver disease? Unfortunately, it's very, very common, especially in our Western culture here in the United States. So we know that research estimates that about 25% of people worldwide actually have non-alcoholic fatty liver disease. And the highest rates are now in South America, the Middle East, Asia, the United States, and also Europe. We know that non-alcoholic fatty liver disease and non-alcoholic steatohepatitis for years and even still currently are under-identified and undertreated, because it too, similar to high blood pressure, can be a very silent thing. We know that these fatty liver conditions are underdiagnosed due to the lack of disease awareness, right? Because only in the past decade or so has the medical community and scientists become more aware of fatty liver disease. So symptoms that are very difficult to identify, right? Current screening procedures, limited treatment and management options. Most people aren't really told of fatty liver disease unless it's something incidentally. You get your blood work done for maybe work, for example, and you realize that your liver function tests in your blood are elevated, which then send your doctor down a spiral to try to determine what next for this patient. And within that evaluation, an ultrasound might occur, and in that ultrasound, it suggests that you might have fatty liver. Then you kind of land on our doorstep to come and talk about what is fatty liver, what are my next steps? And then we take your care over by staging your potential liver disease and trying to explore whether or not you actually have something more going on, or do you simply have simple steatosis or non-alcoholic fatty liver disease. So we know that non-alcoholic fatty liver disease really is running in parallel with increasing approximately at the same rate as obesity. So as our obesity rates grow in Western culture, specifically here in the United States, we know that our non-alcoholic fatty liver disease rates are also increasing. So global overweight and obesity rates have nearly tripled since 1975, with more than nearly 2 billion adults overweight or obese. We call obesity an epidemic that is becoming a global pandemic in the years to come, were it not to be intervened. Scientists and medical individuals are working around the clock to try to identify ways in which that we can combat this epidemic of obesity. And next to that, the epidemic of rise of fatty liver disease. We know that non-alcoholic fatty liver disease is one of the most prevalent causes of liver disease in adults and children worldwide. And we know that NASH is expected to become the leading cause of liver transplantation in the United States between currently and 2025. It's really a grim reality if we let these things go. But the truth is that while we may not have wonderful, federally approved, FDA approved medications specifically for fatty liver disease that's currently approved, we do know that lifestyle intervention plays a huge role in the reduction of fatty liver disease. So what are the risk factors of fatty liver disease and NASH? So you are at greater risk for developing fatty liver disease or NASH if you are overweight or obese. We know that overweight or obesity really is classified on a scale. Individuals who have type 2 diabetes or those with pre-diabetes or even insulin resistance, those individuals are at greater risk. Individuals that have abnormally high levels of fat in your blood, which may include high levels of triglycerides, high levels of the bad cholesterol known as the LDL, or low levels of the good cholesterol, which is HDL. So when you come to our clinic, you may have seen us draw blood tests for your cholesterol and your lipids, and you may wonder, well, my primary care does that. And we work simultaneously with your primary doctors to ensure that your lipids are well controlled. And we may then say to you, hey, you need to work a little closer with your primary doctor and also with your lifestyle to better get those levels in check so that your fatty liver risk does not continue to escalate. Further, those who are at risk are those with metabolic syndrome. And a metabolic syndrome is really a classification of a conglomerate of things. So in order to be diagnosed with metabolic syndrome, any of these things that I'm going to list here below, 3 of the following conditions must be present in order to win a diagnosis of metabolic syndrome. So do you have a large waist size? So obese with body fat concentrated around the waist, okay? So basically, is your hip to waist ratio disproportionate? Do you have the diagnosis of high blood pressure? Do you have the diagnosis of high blood sugar? Okay. Do you have high levels of triglycerides in your blood or low levels of the good cholesterol known as HDL? If you meet 3 of those bullets, you would be classified as a diagnosis of metabolic syndrome, putting you at greater risk in the development of fatty liver disease or NASH. We also note that there are different populations who are at greater risk for fatty liver disease. Individuals of Hispanic or Asian descent are known to have a greater propensity of developing fatty liver because of genetic makeup. These are some rare bird kind of conditions in which people will deposit fat more readily or easier at the site of the liver than other populations. So when people come to our clinic, we will assess them for these more rare conditions, that these genetic causes for fatty liver disease, and make sure that we rule those out to ensure that we're not dealing with something more than just poorly managed blood sugar or poorly managed cholesterol. Individuals who have obstructive sleep apnea, as a result, when you do not get appropriate sleep, there's a hormone called cortisol that is not appropriately regulated. And when you don't get enough rest or you have ill rest as a result of an obstructive sleep apnea, we do notice that the incidence of obesity and fat deposition will increase around the site of your liver. We do highly encourage our patients with known obstructive sleep apnea or suspected obstructive sleep apnea to be assessed by the appropriate medical provider and also explore the idea of something to assist with their obstructive sleep apnea on their journey to weight loss. So maybe the utility of a CPAP as they're working on their diet and lifestyle. People who take certain medications increase the propensity of someone to develop fat at their liver. Steroids is one of them. Steroids are also known as glucocorticoids or corticosteroids, for example, prednisone. People who are on prolonged use of prednisone, we know that can attribute to the increased fat accumulation at the liver. People who are taking like hormone replacement therapy, we call this synthetic estrogens, for example, you are at a greater risk for developing fat around your liver. There's a drug that's used for some heart conditions called amiodarone, drugs that are used as treatments for conditions like inflammatory conditions such as rheumatoid arthritis, like methotrexate, okay, tamoxifen. So here's just a few medications that certainly can actually cause an increased risk of fatty liver disease. The other thing we do at our clinic, whether you knew or don't know, is we actually strictly analyze your current medications. And then we make recommendations back to your prescribing provider as to this drug actually could worsen someone's weight gain. This drug, as a result, could worsen someone's exposure for our potential for fatty liver. And then we'll make recommendations. Consider alternative, or consider, and then we'll list a name of drug. Now, sometimes patients take medications that don't have appropriate alternatives, and we have to be okay with that. But what we try to do is optimize medications to really promote your liver health in a way to reduce your risk for development of furthering your fatty liver or development of NASH. We also know that a condition called polycystic ovarian syndrome will increase the risk because of androgen discord or hormone discord in one's body to put more fat at the site of your liver. So how do we diagnose non-alcoholic fatty liver disease or non-alcoholic steatohepatitis? So again, it's really hard to observe these symptoms in yourself or in people who surround you, especially in those early stages. But there are several tests that we have that we can use to diagnose NAFLD and NASH. And usually what happens is we first start with a general clinical history. We ask you a number of questions, right? Do you drink alcohol? Which can be frustrating for our non-alcoholic fatty liver patients because people think just because they have high liver function tests that instantly it's coming from alcohol consumption. Well, we know better working in the world of liver disease that this is not often the case. But we'll ask you some history questions. We'll perform a physical exam. We try to feel for the border of your liver. We also try to look at the color of your skin. We look for swelling in your extremities. We look at your eyes. We look at the neuro response potentially. So things that physicians and advanced practice providers such as myself have been trained to do, especially as it refers to liver disease. Following our general history and exam, we oftentimes will draw blood tests. And to you, it seems like we're taking all of your blood because that first initial consultation, as you may or may not remember, is we ordered blood tests, and it's sometimes a lot of blood tests. We do that because we want to rule out anything that can be rare as well as common. We can't in good nature tell you that you just have fatty liver disease if we haven't assessed for viral diseases of hepatitis, or if we haven't assessed for autoimmune causes of hepatitis, or if we haven't assessed for drug induction or genetic causes or congenital causes. So that is responsibility rests on our shoulders to ensure that you do not have concomitant disease, or to identify that you do and work you up according to what your specific situation is. We also use imaging to help us because we really need a good picture of what the structure of your liver looks like. People who develop fatty liver disease, sometimes their liver becomes enlarged or big. We call that hepatomegaly. The liver becomes enlarged. We can assess how large a liver is with ultrasound, MRI, or special CT scans that will look specifically at kind of those layers with and without contrast. We also, in addition to looking at the size of your liver, we assess the architecture of your liver. Does it appear nodular? Your liver is something that is a very smooth contoured organ. When it becomes nodular, we worry about development of fibrosis or fat deposition in a way that looks unhealthy. So an image tells us a lot. When someone moves from simple steatosis and kind of moves into the NASH and advanced scarring, we do routine imaging of your liver, because you remember how I said those with cirrhosis or advanced scarring do run a risk of developing liver cancer. Every 6 months, we actually image the livers for someone with advanced scarring to try to catch any growth that may be new in the liver so that we can intervene on a new developed liver cancer were that to happen. The other thing that we do is something called an elastography test. There's transient tested one test called Fibroscan. And a Fibroscan is a machine that we use in office. To you, it's very much like an ultrasound. There's jelly on a probe. They have you lie in a bit of an uncomfortable position on a bed that's usually not really comfortable. They'll have you stretch your arm up over your head so that they can open up the rib cages, and so that that probe can actually send a shear wave into the liver to determine how much elasticity is there. So this will measure kind of the stiffness of your liver, if that makes sense. And this test will give us a score. It'll tell us a score measured in kilopascals, which then directly correlates to your fibrosis score. Are you an F0, an F1, an F2, an F3? We call this staging. An elastography test or a Fibroscan is a form of staging. It tells us, do you have any scarring? Similar to a Fibroscan, where it's using this shear wave technology, there's also something called an MR, so a magnetic resonance elastography, which to you, it looks just like a normal MRI, but this time they're also able to measure the elastography of your liver. Both of these are great tests. Why? Because they're non-invasive. Now, some of us don't really love confined spaces. We have this kind of plague of claustrophobia. And so in that regard, sometimes an MRE is not a great option for those claustrophobic patients. And so these two tests are good initial staging tests. More sensitive than the Fibroscan is MRI. The definitive test about what actually is happening in your liver is known as a liver biopsy. A liver biopsy, unlike its counterparts of the Fibroscan and the MRE, is invasive. This is a procedure where most frequently you are awake. You're given agents to kind of help numb and help with the pain. But you're brought to a procedural room where usually an interventional radiologist, who is a physician, will actually, under sterile technique and under the guidance of imaging, either an ultrasound or a CT scan, they will direct a needle into your liver and pull out very small portions or a biopsy of your liver, so that tissue can be analyzed under a microscope by a physician known as a pathologist. This pathologist will then provide your medical provider, such as Dr. Roman or myself, with their analysis of that tissue. Then we can determine what really is the root cause. Do you have fat accumulation at the site of your liver? Yes or no? They'll tell us. Do you have inflammation as a result of the fat? They'll tell us. So they can tell us if it's simple steatosis, like NAFLD. They can tell us if it's NASH, and they'll give us these very poignant scoring systems that we can put you on a spectrum of where you might be in the disease. It'll also tell us if there's anything else underlying that might be going on. Maybe you have autoimmune hepatitis as well as fatty liver disease, and that really helps guide your medical providers in how to best care for you and your liver health. This will also tell us how much scarring is present. Do you have fibrosis, yes or no? And so the liver biopsy is the definitive diagnosis, albeit invasive. Some patients aren't candidates for invasive procedures because their health doesn't allow it. Maybe they have a bleed risk. So we have two other excellent entry options to kind of stage the scarring of your liver, known as a Fibroscan or an MRE. Dr. Roman or myself will determine, based on your health and your condition, what test is best suited for you. And we never rush someone to have an invasive procedure unless we feel that it's necessary for a patient. So Fibroscan, I'm going to go ahead and play this video so that you can see what to expect if we were to order a Fibroscan on you. Okay, so now that you've at least seen a visual of what a Fibroscan is, you can now better understand that there is this gel form that's placed on a probe, and it looks very similar to an ultrasound. But as you had seen in the video, what the operator will do is position you in a way to open up your rib cage so that they can better assess the liver tissue. And as a result, we get two scores, one to tell us your scarring, as I had mentioned before, and the other one to actually allow us to determine how much fat accumulation might be present. While this test is not 100% specific or sensitive, it certainly is a great non-invasive early staging process that we use in a lot of our patients because it does give us a glimpse into what could be going on with your liver currently. So what happens if I'm diagnosed with non-alcoholic fatty liver disease or NASH? So again, as I said earlier, that currently there are limited approved medications for fatty liver disease. However, it is possible to stop it from progressing to severe liver disease or liver damage through lifestyle change by focusing on physical activity, nutrition, and weight loss. We recognize that we oftentimes are the ones giving the hardest prescription out there. You come and see us and we tell you things like, man, you just got to change your lifestyle, which is the hardest thing to do, because we work, maybe we have illness and can't exercise, maybe we have limitations, maybe we have people who are dependent on us, maybe if it's aged parents, maybe if it's children, maybe it's significant others. Life happens, and we recognize that you can't treat every single individual as a population, but rather we must look to you as an individual and try to find the best approach to optimize your own liver health. So yes, while we do put that burden on you and say, listen, we need to be more physically active, we need within your limitations, we need to eat nutritious foods, we try to pair you with resources such as nutritionists who've really been trained in liver disease and how we can best optimize this. And it requires your efforts to do this on the day-to-day, but you're not without support. So we know that there are various research trials looking at medications for non-alcoholic steatohepatitis as we currently are in this season of life. And we believe and we're hopeful that, who knows, but hopefully in the near future and not the distant future, that we'll be able to identify some sort of more tangible treatment for patients to help their NASH specifically. So currently, is there a medication that's FDA approved for NASH? The answer is no. Are there clinical trials available for patients with NASH? The answer is yes. Do all patients with NASH qualify for clinical trials? The answer is no. So we may have a conversation with you at our clinic. If we see and recognize you as a potential candidate for a trial, we may then bring up this trial to you and say, you should consider this, or here's what this is, and then you will then get the chance to talk to our nurse navigator, and then eventually get to speak to our translational research team, who are the ones who are specifically conducting the studies after having a chance to read the consent form, the risk, the benefit profiles. And then you will go through a process that determines whether or not you are included in this trial or qualify, or whether or not you may not qualify for this trial. So there's research trials that are out there. Some of you are leery of clinical trials and some of you are supportive of them. So understand that research is really what puts us where we are today. And while we, Dr. Roman and myself, have nothing to urge in regards to twisting an arm to get into research, it is our job, however, to present you with your opportunities and what might be available out there. So we may have those conversations, but we also respect, no thank you, I'm not interested as an answer as well. This picture actually does a really good job, in my opinion, of kind of displaying what liver health can look like. A healthy liver is kind of to your far left. You see it here as this very smooth contour, very healthy appearing, this kind of dark pink versus red or purple. You kind of choose the color you like to see. And then from there, as it becomes a little bit scarred, you notice that that smooth contour actually becomes a little bit geographic or abnormal in appearance. The color can change a bit more. Cirrhotic patients, of course, you can see it becomes nodular in appearance. And this picture doesn't do this that well, but it becomes shrunken in size. So what happens is your liver at first becomes enlarged with fat and inflammation. That's called hepatomegaly. But then eventually, as the liver develops more and more scarring, it almost kind of wants to give up a little bit, and it becomes shrunken and nodular. And then lastly here is you can see how a cirrhotic liver then can present with nodular growth and cancer development. So that's kind of the stages of how one liver moves from healthy all the way to a cirrhotic liver, and then eventually even the risk of the cancer development. So people with NASH are at high risk of developing other conditions, such as metabolic disorders and cardiovascular diseases. And actually, we know from evidence-based medicine that cardiac-related deaths are one of the leading cause of mortality for people living with fatty liver disease. So usually it's not their liver that kills them, it's what gave them fatty liver or this metabolic disease that's poorly controlled that leads to cardiac death as a result. So by optimizing your health, your diet, your exercise, will also optimize your cardiac health and your global health so that you can actually be a whole person in a way that's healthy. We know that if fatty liver is left untreated, it can lead to NASH. NASH then can progress into cirrhosis and liver cancer, or even result in death, as it's expected to become the leading cause, again, as I said before, of liver transplant. And we're in that season currently. This is what we're seeing. So here's more of a pictogram, less of that actual liver kind of picture or tissue, but this is more of an animation. You have a healthy liver over here. You have fat that starts to accumulate around the liver at greater than 5%, known as non-alcoholic fatty liver disease, assuming there's no alcohol, which then at that fat will cause those liver cells to become angry and cause inflammation, and that fat accumulation leads to inflammation, and as a result, the inflammation leads to tissue damage. Tissue damage is known as scarring or fibrosis, and then advanced fibrosis leads you to cirrhosis and that potential risk of cancer and that potential need of a transplant. And again, not all people with cirrhosis are eligible for liver transplantation. That must be very clear. So what are options for treatment for fatty liver disease? So the more serious NASH becomes, the more difficult it is to manage. So the amount of fat in the liver can be reduced through lifestyle changes and weight loss. We know that, it's proven. It happens, and we have people who do this successfully, but not without effort, not without trial, not without failure in amongst the process. But truthfully, we can only call it a lifestyle failure if you fail to continue to move forward. Otherwise, it's just a bump in the road. Remember, a lifestyle is something you've learned over your whole life. We're not going to undo that overnight. But what we can do is make small strides, and then we can encourage you that when you fall off your motivation to get back on, because it's not a failure unless you fail to progress or continue to try. So that's always our encouragement. We understand that your dietary and lifestyle changes can improve NAFLD and NASH at all stages. We also understand that when you have fibrosis stage 1 or 2, getting rid of the fat at your liver can actually improve your fibrosis or your scarring, which is shocking. The liver is a very resilient organ. However, when you develop advanced fibrosis in the form of cirrhosis or fibrosis stage 3, kind of getting rid of that scarring is not really an option at that point. But just because you have cirrhosis, that is not a death wish. What that means is that we can optimize the remaining function of your liver, even in the presence of cirrhosis. And by eliminating that fat really provides your health and your body with the chance of living its healthiest version. So healthy food choices, that's one thing we can do. Limiting your portion size. What time of day are you eating? If your largest meal is in the evening, that should be adjusted, because remember, you really want your fuel to fuel you through the day. You don't want to fuel up just before you go to sleep, because all the excess calories will deposit as fat. So we recommend that your smallest meal of the day actually is your last meal of the day. And it's hard to say dinner, because I know some of our participants likely work a third shift or a second shift. So whatever your last meal of the day is, the time before you go to sleep, make sure that that's your smallest meal. Also, for those who are doing a 9 to 5, make 7 p.m. the last calorie consumption of the day. Okay, give your body the ability to utilize the consumption of calories as energy and store less, because any energy or calories consumed that's not expended as energy, that is stored as excess fat. And obviously foods that are high in fats, like saturated fat, or foods that are high in carbohydrates, a carbohydrate is processed as a sugar in your liver. And that excess sugar leads to excess fat accumulation. So we really tell our patients to focus on making sure you have good lean protein, chicken, fish, and also making sure that you have good servings of vegetables to maintain your fiber. And that also, those two combinations together will help you feel full longer. Because sometimes we eat just because we don't feel full, or sometimes we eat out of boredom. But by choosing the right foods, that can be helpful. The other is your physical activity. Now, some of you can't jump up and join the Tokyo Olympics, which I respect, and nor is that what we would ever expect someone to do. But what we do expect is, within your limitations, to find a way to move your body. Even if it is, if you're unable to ambulate or walk, maybe you aren't able to walk. Maybe what you can do is get a resistance band. And you can have that resistance band, which are fairly cheap at like a Walmart or something, where you can purchase them for a few dollars. And you can use these resistance bands to, really kind of contract those muscles to promote muscle health, because the more musculature you have within your body, you have a higher risk of being able to lose total body weight, which in turn can help you lose fat accumulation. If you can't do weight-bearing exercise, if you have access to a pool, and I understand not everybody does have that luxury, but if you do, maybe doing some sort of water exercise with low resistance for joint pain. If you're sitting all day at work and you tell us, well, hey, I can't make time for this, and if finances allow it, there's these little pedal bikes that go underneath your desk, and maybe you can do that. Or at least set a timer on your phone and stand up and maybe do calf raises, or walk up and down the hall of your office or of your home. So making small adjustments to your daily lifestyle, while it may seem meaningless, truthfully can make an eternal impact on your global health. We just have to make daily changes. And the other bullet that I'd like to mention is adequate rest. That hormone called cortisol, if we don't allow that to regulate appropriately and fall when it needs to, unfortunately, our bodies kind of say, hey, it's going to help us gain weight, right? If this cortisol is not regulated, it's going to promote weight gain. So adequate rest is something that we like. We also prefer resting at nighttime. Circadian rhythm is a big promoter of of weight gain if it's dysregulated. But when you have adequate rest and at the nighttime hours, you usually can better regulate your circadian rhythm in a way that actually can help you or promote the ability to lose weight or to further prevent weight gain. So a lot of us will say, then what specifically can I do to help myself? So we talked about a few things, and here's some tangibles. By no means is this all of the things you can do. But number one, you can read the nutritional labels to look for hidden fats and sugars and sodium. Here's something unique about the labels on our foods. The things that are listed first in that long list of ingredients are the things that are the most potent or that has the highest concentration within the food. So if the first thing says high fructose corn syrup, it's likely not a good thing to consume, because the largest ingredient in that product is high fructose corn syrup, which metabolizes as a starch, which then is a sugar, which then is deposited as a fat in your liver. Okay, so reading labels, becoming familiar, educating yourself through exposure over time. And then eventually, once you've really become educated on these labels, you'll know what you should and shouldn't have. There's this kind of age-old thing where they tell you need to shop the periphery of the grocery store, because that's where you'll find your most whole foods and the least processed foods. And by no means is this a rule, but in most grocery stores, the majority of your processed foods lie in the center of the store, right? They have a shelf life. If there's a shelf life, there's a preservative attached to it. And those sometimes can be a little bit more harmful and promote weight gain. So the whole grains, the whole foods, Dr. Roman says something like this, and I don't want to mess it up. She says, if it's roamed the earth or grown from the earth and you eat it in its natural form, it's the healthiest version of the food for you. And I couldn't agree more with that. And you can identify these types of foods usually on the periphery of the grocery store. You should have a personal goal of 5 portions of fruit and vegetables a day. We, when it comes to weight loss, we prefer vegetables over fruit, because while fruit is good, it's very healthy for you. You don't want to overdo fruit because fruit has sugar in it. Fructose can be processed as excess fat if we don't use it. But the idea is that you really have a goal of 5 portions of fruit and vegetables a day, and make sure that you don't substitute your vegetables for extra fruit. Yeah, it usually tastes better because it's sweet, right? We like that sweet. But the truth is you need the nutrients from the vegetable as well. And if you can eat them in the raw form, then you do not chelate or get rid of some of those nutrients. So steamed broccoli, sometimes we prefer over raw broccoli. But if you can stomach that raw broccoli and your GI tract allows that, maybe you've had like a gastric surgery in the past that doesn't allow it, we understand that. So make sure you adjust it to your limitations, but do try to get as many nutrients in those 5 portions of fruit and vegetables a day. Eat foods that are high in fiber, including whole grains. Fiber is very good for motility, very good for regulation, and it actually helps promote or helps distract from further weight gain. Use extra virgin olive oil as your added fat if you are having to use anything else. There's some of these adjuvants like avocado oil as well that seems to work well for patients. We want to stay away from a lot of high saturated fats. Consuming fish 2 to 3 times a week is something that we certainly do recommend for patients. And when they do have fish consumption, it's real easy as long as you like fish. It's not so easy when you're not a big fan of fish. So we do understand if that's a limitation for you. So keep that in mind. Fish is a good thing. We like that as one of our lean proteins. We always tell our patients, as you know, since that's who's here today, is to switch your sugary drinks and sodas for water, okay? We want you to avoid sugar-sweetened beverages at all costs. You're drinking calories and you don't know how many of those are wasted calories. So if you can't drink plain water because you don't like it, sometimes we recommend those carbonated waters that are very popular now, right? You'll see a lot of these different name brands, they have no calorie and they just have a little lemon flavor, a little grapefruit flavor to them. And those can be appropriate if you do desire the fizz. Avoid any processed food, specifically fast food. The more you can dine at home, the more you know what's in your food. So sometimes, the steak and potatoes taste really good in other places because they add more things to it that you probably just wouldn't at your own home. So eating at home, avoiding processed foods. And if you do dine out or your job doesn't allow you to prepare your own food, know what whole foods you are eating and avoid processed foods like fast food. Again, avoiding saturated fats. We're not telling you to avoid fat. We're telling you to avoid saturated fat. So we do promote avocado. If you need a snack, something that will fill you up, avocado is a good option. A palm full or less of nuts like almonds also provides you that sensation of being full. We call that satiated, but it also gives you good healthy fats and protein. Your aim also is for 60 minutes of physical activity a day, and it does not have to be all at the same time. So walk more, exercise, take the stairs whenever possible. The culmination of exercise in a day, we like to get to 60 minutes, but that's not where we tell our patients to start. We may say start 15 to 20 minutes, 3 days a week, and then we'll go to moderate exercise further. We'll say, why don't you now do moderate exercise 30 minutes for 3 to 4 days a week, and we'll increase that as your tolerance goes. But it does require exercise in order to kind of move forward with your global promotion of your health and reduction of fatty liver. So what can my healthcare provider do for me? What is it that we can do? So we do schedule regular evaluations to determine the severity and provide consultation on treatment. So this would be like staging your liver disease, watching to make sure that there's not any digression of your liver health. Sometimes we do blood tests or imaging of your liver for the reasons we've talked about before, to look at your liver function test, to measure how much cholesterol or what your blood sugar is doing. We also order images to look at the structure or the architecture of your liver, excuse me. And then we also may refer you to some of our colleagues like nutritionists who are the professionals in making this work. And a lot of people, it's a misnomer because a lot of our patients have actually seen nutritionists even before they come and see us, and they think, well, that didn't work last time, it's not gonna work this time. We'd really encourage our patients to have a very specific conversation with our nutritionist. And that is this: here's what I do for work, or here's what my daily routine is, or my lifestyle is. Here's the foods I like, here's the foods I don't like. And then challenge the nutritionist to work within some of your confines to really kind of develop a good nutritional plan for you that's sustainable. Because if it's not, we all know the answers. What are they going to do? Tell me not to eat ice cream and cookies. Well, yes, we know that those things are not the best options, but is there a way we can take the things you like, take the things you don't like, take your lifestyle, take your sleep pattern, and optimize your nutrition? And I think the answer is yes, but it still requires effort. So nutritionists provide that professional, individualized review of current eating and lifestyle habits, which is important. You have to share that with them. And then evidence-based nutrition treatments. As we know more about fatty liver disease, they're able to integrate specifics of nutrition and foods that can really promote liver health. Assist with setting realistic goals and not something that seems way too far-fetched, because remember, this journey to a lifestyle change is baby steps and something sustainable, because what happens is people inevitably become frustrated. They miss these saturated fat foods that they've been eating for 40, 50, 60 years of their lives, and they're just not ready or not willing to make the change. So it needs to be sustainable. They also help provide guidance on overcoming barriers to achieve positive change. We partner with them to do that. So healthcare providers can provide a variety of options to treat fatty liver disease. And this includes lifestyle things that we had talked about, lifestyle modification through nutrition and physical activity, but you should only expect to lose 3 to 5% of your total body weight through this alone. So sometimes that requires the help of medications. And fatty liver disease specific medications, while there is no medication available to reverse the fat buildup in your liver, there are several medications that are in clinical trials being tested currently to do this, okay? What we'll try to do is help optimize the management of your diabetes, with the help of your endocrinologist, your cholesterol with your primary care, your high blood pressure, or even conditions that actually further complicate NASH or fatty liver disease. But even though we don't have medications to help get rid of the fat at your liver yet that are clinically approved, or FDA approved rather, we do have weight loss medications that do help our patients kind of get over the hump of stagnant plateaus or weight loss, which can provide a 7 to 10% total body weight loss by utilization of these medications. Now, not all patients lose weight on these medications as others do, and none of these are magic pills. It's simply something to help aid in weight loss. I've listed a few of them here. Casemia, which is a combination medication of enteramine and topiramate. Some of you may have used those as monotherapies kind of alone in the past. Contrave, also a combination medication. Saxenda. And then we also have GLP-1 agonist and orlistat, which is another approach. And then we also have phentermine. So some of these are FDA approved, and then we also have off-label utility of drugs such as topiramate and bupropion as monotherapies that we can consider in patients who are not eligible for FDA approved drugs. One limiting factor is it depends really on your insurance coverage as to how much they'll pay for these drugs. And some insurances cover them well, and other insurances don't cover them well at all. So Dr. Roman and myself, or people like us, who will look at these drugs, look at your health history, and determine which of these medications you would be a good candidate for and provide you with that direction, if any at all. We also have meal replacement programs, something called OptiFast. This is something that we kind of reserve because this OptiFast is not something that we ever jump to. It's usually for people who failed not only diet and lifestyle things, even with their ongoing trial, in addition to kind of these other oral medication. This is a 26-week medically supervised program. It's a meal replacement program. You can expect a 15 to 20% weight loss, but the truth is it's a very, rather grueling process at times. And it's something that we kind of reserve. As I said, it's really not our first and foremost treatment, but it is an option. Bariatric surgery is something else. So a sleeve gastrectomy or a Roux-en-Y gastric bypass, you can expect to lose up to 40% of body weight, 25 to 40. And research shows that some individuals need to lose up to 7 to 10% of body weight to reduce liver inflammation. So you will kind of surpass that. Individuals who have a BMI of over 40, you may be a candidate for weight loss procedures such as gastric balloon or gastric surgery. Or if you have a comorbidity such as renal disorder or kidney disorder with a BMI a little bit lower than 40. And we will also oftentimes refer those who look like good candidates to our bariatric surgeon for consultation. Clinical trials, as I mentioned before, research looking at various interventions to treat fatty liver. We have a few trials going on now, and we'll communicate if we believe that you might be a good candidate for this at your office visits. And then there's also liver transplantation, which is reserved for patients with cirrhosis that leads to liver failure that may qualify for a liver transplant. And there's a very grueling process, a very long workup process for these cirrhotics that actually have a decompensated picture, which means that they're very sick cirrhotics and their liver function is not well preserved. And so that's kind of reserved for the very end, the most sick, the most ill patients with liver disease. So that concludes our discussion for today. And I wanted to take the last just couple minutes here. It looks like 3 or 4 minutes to answer any questions that you might have. We can do that by unmuting your mic, or you can put those in the chat in these last couple minutes. And if there's no questions, that's okay. We want to thank you greatly for your joining us today. We do appreciate your presence, and we want to continue to be a resource for you as our patients as we navigate your health journey. And we hope that this information has helped at least provide a little bit of foundational information. Thanks again for joining us. We will have another webinar series the first Friday of every month from 12 to 1. For 4 series. This is 1, so we have 3 to go, and then the series will start over again if you happen to miss one. So thanks again for joining. Have a wonderful weekend and a wonderful holiday.